Well, good morning, you all. I'm Ray Townsend from the University of Pennsylvania in Philadelphia, and my task this morning is to make 2 points. The first point is that no matter how you measure blood pressure, and I'll tell you now, it doesn't matter whether you use an aneroid, an oscillometric, a kiosk, or whatever. If you don't do the technique correctly, you have a garbage in, garbage out phenomenon. And then the second is that when it comes to the actual measurement techniques, and we're going to talk about 2 mainly, oscillometric and aneroid, each is wonderful, but each has a couple of items associated with it that I think often we don't take into consideration in our daily practices, and especially with respect to our relationship with clinical engineering. I had no disclosures. This is my agenda, and here we go. So I thought I would start with just some terminology to make sure we're all on the same page when it comes to blood pressure. So when it comes to blood pressure, what are we actually assessing? And the answer is we're assessing the excursion around the pressure wave. We're not actually looking at any qualifications or components of the pressure wave itself. We're simply looking at the top of the wave and the bottom of the wave. And why we do that is because it has something to do with death and disability and diseased organs. The World Health Organization took hypertension from number 4 in 1990 to number 1 in 2010 as the single most important phenomenon associated with shortened life or living with a disability such as a heart attack, heart failure, stroke, etc. And secondly, this is the excursion thing. We measure systolic and diastolic pressure, but the body is not so much interested in that. It's really more interested in the mean arterial pressure. And it accepts the excursions because of the mechanism by which it generates the blood pressure, which is a periodic contraction of this thing called the left ventricle. So that's an unfortunate necessity, but nonetheless, mean arterial pressure is what the systems are after and what our regulatory phenomenon govern. Does it matter which artery we use if we come to arterial stiffness, which is the last 1/3 of this talk? And the answer is yes, it does. The aorta is the main place where we get information about the health of the circulation and the consequences associated with arterial stiffening. And why does it matter how stiff an artery is? Because independently of the blood pressure itself, arterial stiffness is a predictor of death, disability, and target organ damage. So here's the issue with respect to arterial stiffness from a population where arterial stiffness is like having your brain on 4 loco, and that is a dialysis population. The French are about 3 decades ahead of us here in the US because they incorporate arterial stiffness into their epidemiology programs and into their high-risk populations like the dialysis unit. What you're seeing here is a group of individuals who had their arterial stiffness measured 3 different ways. The carotid to radial, so it's the velocity of the pulse wave travel across a segment of the artery, and you can do the arm, the leg, or the aorta. And when you look at these 3 graphs, and these are all the same people, when you look at the aorta and divide the aortic pulse wave velocity, the aortic stiffness, into tertiles, you don't need Dr. Welton or others here to tell you that this curve here doesn't look so healthy compared to that one when the idea is survival. So the least survival is those with the fastest pulse wave velocity. The best survival is those with the slowest in the aorta. Take those same individuals, measure their velocity in their arm or their leg, and you can't disentangle the curves. So moral of story is when we measure arterial stiffness, we need to use the aorta. Now, when it comes to blood pressure measurement in the clinic, I'm not going to take time to go over this. You've actually seen this same phenomenon 3 different times now. But when you add up the number of things being done wrong here, it's all 6. I mean, everything you can do wrong is being done wrong in this particular picture. I used to show this when I did the prime med circuit in terms of just the issues with respect to correct technique. If you don't use correct technique, you can't trust the data. Now, there are 2 800-pound gorillas, one on each side of the room when it comes to how we do office-based blood pressures. Aneroids were actually co-developed with the mercury sphygmomanometer. You will see that aneroid phenomena date back to 1897, same as 1896 with the methods of using mercury. Now the mercury's gone, aneroid is still standing. But in the last couple of years, especially oscillometrics, push a button, bzz, and a result pops out. These have become very much more popular because they don't require using a human ear with all the things that happen with respect to our hearing, and we'll talk about these phenomenon under oscillometric in a minute. So looking at aneroid, a couple of things. You have to inflate the cuff and listen. Aneroid has all the same phenomenon that a mercury-based blood pressure result does. It needs the same size cuff, etc. You got to have a good ear. You got to use correct technique, proper cuff size, etc. But when done correctly, aneroid is just about as good as a mercury-based blood pressure measurement. So the accuracy issue is something that we typically sweep under the carpet and don't actually pay attention to. And it is the Achilles heel of the phenomenon. Because if you look carefully at this gauge here, get your binoculars out and look, that needle is not in that little box at the bottom, even though it's not connected to anything. But there's two elements of calibration in an aneroid phenomenon, only one of which is having the needle rest in that box at the bottom. You have to be able to show in 50 millimeter of mercury increments around the gauge that when it says 200, some device connected to it in a Y fashion also says 200. And that's where half the calibration issues come from. And we don't usually measure that. We look at the gauge, the needle's in the little box at the bottom, we're good to go. And guess what? We are not good to go. So there are a lot of moving parts in this phenomenon. The reason it's called aneroid is it has no fluid, whether it's water or mercury in it, so it's using air. And it has to have a bellows mechanism in it so that the air pressure is captured. And then there has to be all these set screws and other things that connect it to the actual gauge itself so that when you pump up air, it reflects in a change in that particular needle. And as you know, aneroids come in three flavors. You got the kind that you wander around room to room with, you got the kind that you wander around room to room with on a set of wheels, and you got the kind attached to the wall. If you think just about the wear and tear on a daily basis, the wall cuff may get a fair amount of usage, but it only rocks back and forth a little bit. But if you whack it a few times, the moment you tap the dang thing, it's out of calibration. The ones that we wander around with room to room, they're even more susceptible to miscalibration because of wear and tear and use. And you got very sensitive set screws in there, and there are at least two of them that are important, one that zeros and one that translates the magnitude of the pressure change to a magnitude of a needle change. Every time you whack the thing, drop it, every time the patient accidentally nails it with their elbow, it loses a little bit of calibration. And the recommendation, you'll see this and I'll say it again in a second, the recommendation is to make sure these things are calibrated when they're in frequent use like these two, every 2 to 4 weeks. And the wall-mounted ones at least at 6-month intervals. We have 18 exam rooms in the kidney division that I work in our outpatient area. There's not a single one of our aneroid devices that has been checked by clinical engineering with a little tag on it in the 9 years we've been in our current building. And I think that that's not unique to the University of Pennsylvania. So the issues here with respect to the aneroid method, I mean, the strengths are it's been around for as long as mercury. We got lots of data with it, and it works. There are many brands, there are many models, and many of them come with these lifetime calibrations. Problem is you got to put them in a box and send them back, and then hope that, Conan, the UPS deliverer, isn't the one who dropped the box back off and let it fall on the ground outside your door when it came to the return method. The accuracy can be a little problematic, but here's the issue. If you actually go around snooping, like on a JCAHO side visit here, and you look at how many fail calibration in one of the 50 millimeter of mercury quadrants or quatrants or whatever they are in fifths, 1 out of 3 fail, and in the private practice setting, 1 out of 2 fail. So often these things are just not reading accurately enough, and this is the frequency with which they should be calibrated. So calibration issues and the moving parts in them, and just the amount of time, etc. These are important limitations that occur with aneroid things here. And if you look at it as though you're taking a mercury, all the things that have to do with mercury-based blood pressure measurement are also true in aneroid and oscillometric as well. Miscuffing and malposition of the arm are amongst the mortal sins here as opposed to the venial sins when it comes to the technique. And the issue with calibration can give you a false sense of security. These are examples of oscillometric devices, a home one, an office heavy-duty one, and an out-of-office ambulatory one, just 3 examples of the oscillometric technique. what most people don't realize is that there's a heavy-duty set of electronics behind these things that have developed greatly since the 60s when these things first started coming out. And what we do with a standard mercury or aneroid thing is here, we pump this thing up, it deflates, we listen for the K sounds, we hear the changes, the muffling, and finally the disappearance. Well, all that's out the door. An oscillometric device does not measure the systolic or the diastolic blood pressure. You may have a BP True or an Omron or whatever, an Eckert, who knows, and you push the button and it inflates the cuff and it deflates the cuff and it spits out two numbers, 120/80. Well, it didn't measure either of those. What it measured was the amount of oscillations in a thing called the waveform envelope, which is this little guy right here, which when I get it will come up there. As that cuff deflates automatically, now there's no human involved in the process of making the actual measurement. Once you push the button, it's on autopilot. And as that cuff deflates, the amount of pulsation in it picked up through the segment of the brachial artery underneath that cuff starts to register. And as it registers, it gets bigger and bigger, so you're picking up what looks like huge amounts of pulsation. You're looking at 3 millimeters of mercury of pulsation here. That's why these things are so sensitive to small amounts of motion and other things that create artifacts. But as you can see, the thing gets bigger. It peaks somewhere right in here, diastolic and systolic, with each beat, and that's the mean arterial pressure. At least we predicate all of the science on this, on that widest oscillation being the mean arterial pressure, and that's what these things measure. Now, physiologically, it makes sense because that's what the body measures. We don't treat mean arterial pressure, at least not in clinic. We treat systolic and diastolic. And so that mean arterial pressure is the key here, and getting that waveform envelope to read the mean arterial pressure then begins the secret sauce approach to how to develop the systolic and the diastolic pressure. There are at least 7 different ways to take that waveform envelope and translate it into systolic and diastolic pressure. You know, part of this was driven by Leslie Geddes from Purdue, but others have done this as well. And when you have the mean arterial pressure here, you just backtrack a certain percentage here and say that's systolic, and you forward track a certain percentage and say that's diastolic as the thing deflates. So once you see the mean arterial pressure is 98, and you know the front end and the back end of that, it'll spit out a number here based upon a fixed percentage. This is just one way of doing it. There are 6 others. So the issues with oscillometrics are that they have widespread usage. They're a little easier in many respects. You don't have to have the hearing. You don't need multiple parts. You just need a cuff, hopefully connected to a device whose solid-state electronics are reasonable. So you can do it, especially on autopilot, with something they wear, like the ambulatory that you heard Dr. Vieira talk about just a little bit ago. And when it comes to the automated office blood pressure form of the oscillometrics, it actually moves the ball a little further downfield in terms of the validity with which the readings can be trusted to use in the management of patients with high blood pressure. And AOBP in particular as an oscillometric way correlates a bit better with daytime out of office, ambulatory, good correlation with the issue with eliminating the white coat effect. If you can get a very well done automated office blood pressure in your office, you will virtually eliminate the in-office white coat phenomenon because it's that good. But the limitations are that, especially with AOBP, you got to take a couple of readings, at least 3. BP True, for example, may take 5 or 6, one to settle the cuff and then one at, a minute or 2 intervals. It has errors, and the issue here is that the cuff size matters on an oscillometric the same as it matters on an aneroid. So you can't get away with just using the one size that maybe is connected to your Dynamap or your Omron or whatever. You need to cuff properly. So bigger people need bigger cuffs because all the predicate for detecting that mean arterial pressure is based on the same science that was behind mercury or aneroid methods of measuring blood pressure. The pitfalls with an oscillometry are the same. The whole issue with respect to malposition of the arm and miscuffing, the little cuff on a big arm and that kind of thing. Heart rate variability can drive it a little crazy. So when you see atrial fibrillation, for example, I defy someone to tell me what the blood pressure is in a patient with atrial fibrillation, because there is no such thing as the blood pressure. It's the blood pressure associated with that particular length of time in between the heartbeats themselves. And the issues that are just limiting for oscillometric use are often things like in the field when someone's down with an injury or whatever. If they have a relatively low blood pressure, the oscillometric signal strength isn't good enough. Or if they're in an ambulance and being jostled, like I mentioned, you're dealing with a 3 millimeter pulse pressure. And so when they, especially in Philadelphia, where it's a pothole city, as the thing's hitting pothole after pothole on the way to the hospital, the arm's bouncing all over the place and you can't really get a very good answer. And probably the most deadly aspect of oscillometrics is when you go into Eckerd, Rite Aid, Walgreens, whatever, and you tell a patient, go buy one, and they pick one off the shelf, whether they use Dabble or any other site. When you pick one off the shelf, look at what it says about how this thing was validated. There's a difference between what the FDA does. These are medical devices, so the FDA does clear medical devices. You want to use your smartphone to check blood pressure, FDA has no role. That's recreational, it's not medical. So all these smartphone apps, you can spend up to $5 on one of these smartphone apps to do your blood pressure at home and keep track of it. Those are completely unregulated and completely untested in terms of their validity. But when it comes to oscillometric devices, the FDA doesn't validate them. They clear them. And they clear them through a thing called predicate device. And 80 to 85% of the devices you can buy for a patient or a patient can buy in a drugstore have never actually been validated. They've simply been cleared based upon a prior predicate device. So until you actually measure the thing against some standard you trust to say to a patient, yes, that monitor is working in you, you just don't know. So if you have a lot of faith, go for it. If you want to know better, cut the cards, look at the thing in the office setting where you can verify it. Final thing here is about arterial stiffness. A lot of people don't know much about this because we still don't do it very often, at least in an office setting. In Japan, for example, you do these once a year, especially in your high-risk patients, hypertensives, because it contributes to risk prediction. It has a reclassification phenomenon associated with it, so it improves our ability to detect who is at risk for heart attack, stroke, heart failure, and kidney disease progression. The way in which arterial stiffness is measured is you want to measure velocity. And to measure velocity, you need to know two things: a distance and the amount of time it took to traverse that distance. So to measure pulse wave velocity in the aorta, the only artery where it really matters in terms of outcomes, you have to measure the distance from your two measuring sites, usually the neck and the groin. So you have to have that distance, and then you have to have some way of timing the arrival of the pulse wave in the neck, which is pretty quick after the heartbeat, and the arrival of the pulse wave in the leg, which is a little longer after the heartbeat. So what you see here is the carotid and the femoral. Here are the waveforms here with the tonometer planted over the artery itself. And for timing purposes, this is a standard limb lead 2 EKG. And what software does is it measures the time elapsed between the tip of the QRS and the foot of the wave. And when it comes to the tip of the QRS and the foot of the wave of the carotid, you're looking at 60, 70, 80 milliseconds. But when it comes to the tip of the QRS and the arrival of the wave at the femoral, you're looking at 120, 130 milliseconds. Takes a little longer. So you know the distance, you know the amount of time different between the arrival of the wave here and the arrival of the wave there. So you find those times here, you divide distance by time, and you get a velocity answer. Like, for example, in this case, 5 meters per second. Since there's a bunch of readings here, it also gives you the standard deviation associated with that reading. And like anything, if the heart rate's really crazy and they have atrial fibrillation or lots of PVCs or some other thing, that throws these readings off a little bit, but there are ways to correct for that. What drove the field forward and made it sort of respectable to do, especially in office settings, let alone in cohorts, was the publication of worldwide reference standards. So if you're ever asked, oh, what's a bad pulse wave velocity? The answer is 10 meters per second. What's that based on? That's based on studies, and cohort studies particularly from around the world, that have been assembled over the last 25 years that we've been able to do this. These are non-invasive measures. They're easy to do. They're very robust and reproducible. A fifth grader properly trained can do these things for a living and do them well. What we learned from looking at the pulse wave velocity reference standards is here's your age, here's your velocity here. In healthy people, even in the healthiest person on a non-Southern diet. Maybe they grew up with, a parent who was part of the DASH diet eating study. So they've eaten healthy all their life and they're free of cardiovascular disease. They're still an effective age. Because every time your heart beats, it puts a little tiny bit of micro trauma on your aorta, and that trauma adds up. It adds up into collagen. As collagen increases, stiffness increases. So even under the healthiest conditions, there's a change in pulse wave velocity over time. In those with the highest levels of blood pressure, there's an even greater increase in the pulse wave velocity, the arterial stiffness over time. This back thing here especially is a convex upward type of curve. So age is one of the most common of the components, regulatory components that increases velocity. But throw in blood pressure, cigarettes, diabetes, chronic kidney disease, and arterial stiffness goes nuts and begins to be very predictive. Here's work from Gary Mitchell and the Framingham Project, looking here at MACE, major adverse cardiovascular events, and quartiles of pulse wave velocity. Once again, you don't need to have, the Welsh Center for Biostatistics to tell you that this curve here looks pretty bad compared to these others, and there's actually a nice display over time between them. People with the greatest arterial stiffness are multifold more likely to develop cardiovascular endpoints, including death, even when you control for their blood pressure, comparing these. And this is cardiovascular disease. In the kidney study that I work in, we've looked at the role of arterial stiffness as a predictor of chronic kidney disease progression and death. So death is over here, ESRD is over here, and the typical endpoint of halving of your kidney function or doubling of your serum creatinine or the development of end stage is in the middle here. And since death is usually acknowledged as the most robust endpoint in a fairly large epidemiology cohort, like the chronic renal insufficiency cohort here, it's the one that gets, I think, the most attention. And the faster your pulse wave velocity is, here's the worst group here, here's the best group here, is a strong and independent predictor of death, independent of blood pressure, diabetes, age, etc. So arterial stiffness has at least developed a fairly significant niche in the epidemiology of looking at the outcomes associated with kidney disease. So a couple closing thoughts. Once again, it matters how well you do a blood pressure no matter what technique, aneroid, oscillometry, kiosk, whatever you do. So proper positioning and all those other things are important. When it comes to aneroids, message learned is make sure the calibration is okay. When it comes to oscillometrics, most of these devices are cleared but not validated. They need to be checked on an individual. And when it comes to arterial stiffness, if you see and hear about this phenomenon, it is a recognized epidemiologically based cardiovascular risk predictor. Risk factor, we haven't found good ways to de-stiffen the aorta yet, but God willing, when I get a little older here, perhaps we will, and thank you for your attention.